Hello, everybody. In this presentation, we're going to focus on critical respiratory disorders seen in pediatrics. So our main objectives are to review the structural and physiological differences in the respiratory tract of children, define respiratory distress and respiratory failure, and then examine both upper and lower obstructive disorders. We'll also touch on the assessment, treatment, and education related to those conditions. So respiratory disorders are a leading cause of hospitalization in children. Acute respiratory conditions not only account for the majority of hospital admissions, but also lead to significant absences in daycare and school. When pediatric patients experience a code, it's often due to respiratory distress or failure. Infants in particular are more vulnerable because of their anatomical and physiological differences. And while some children may be severely affected by respiratory illness, others can be managed at home with proper caregiver education. So a lot of respiratory care is supportive. Okay, acute respiratory infections can be classified as either upper respiratory tract infections or URIs, or lower respiratory tract infections. The upper respiratory tract consists of your nasopharynx, your pharynx, your larynx, and your upper trachea. And then you have your lower respiratory tract, which consists of your lower trachea, your bronchi, your bronchioles, and your alveoli. So children's respiratory systems are structurally similar to adults, but there are key differences that make them more susceptible to issues. Their airway diameters are smaller, which means inflammation can easily lead to obstruction. This also results in higher airway resistance, which makes it harder for them to breathe. And then additionally, because infants are smaller, the distance between those respiratory structures is shorter, which allows infections to spread more quickly. The chest wall of infants is less rigid due to the pliability of their ribs, and so their respiratory pump is less efficient. The trachea is also narrower and less rigid, so that can lead to obstruction. And then even just the larger head of a child can cause that neck to flex when they're laying down, and that can lead to a physical airway blockage. Children's lungs physiologically they have fewer alveoli compared to adults, and their lung capacity is smaller. As you guys may know, children also have a higher metabolic rate than adults, so they use more oxygen and they eliminate more CO2 at rest than an adult does. And then this all translates to them just needing to breathe faster to meet their oxygen needs. Their immune systems are also less developed, which makes them more prone to infections. For instance, younger children will often experience more respiratory infections, especially during their first year of life when those maternal antibodies wane around 3 to 6 months and their immune system is still maturing. Breastfeeding does help in transferring some antibodies that are protective against respiratory disease, but there have been limited studies looking at the connection between breastfeeding and respiratory tract infections after infancy. We do know that there are some antibody benefits, but to what extent is still unclear. Children also have shorter eustachian tubes or ear tubes that put them at higher risk of otitis media or ear infections, which are very common in toddlers, along with tonsillitis. Around 5 or so, those viral infections will decrease, and then we start to see more mycoplasma or walking pneumonia, and also group A strep or strep throat. My 11-year-old has had 3 strep infections just this year. They are walking petri dishes. It goes around in that age group for sure. It is also important to briefly mention the developmental differences that can affect respiratory systems. As we learned before, infants explore the world with their senses, and they lack the sense to not put things in their mouth. So this mouthing predominates the first 4 to 5 months of life, and they're at an increased risk for infection just because they're not washing things before they put them in there. Young children will also have limited motor skills, so positioning is very important, especially to help infants maintain their airway when it comes to sleeping. So we've talked about back to sleep for safe sleep, that it's as easy as your ABCs, right? They're alone, on their back, in their crib. And that can also help when they're sick as well. Important to note that infants are belly breathers, and while at times it can look a little different or seem abnormal, this is the expected finding for infants. It's what makes it so easy to count the respiratory rate from across the room because their belly's just going up and down, right? So it's important then, that you're actually looking for other respiratory cues to determine if that patient's in any type of distress. It's also important to know that infants are obligate nose breathers until around 6 months of age. So if nasal secretions collect in their nose, this can block their airway because they don't automatically go to mouth breathing like you or I may do when we can't get air. Now let's take a look at an infant that's experiencing respiratory distress. Respiratory distress often looks like increased respiratory rate, retractions, nasal flaring, and use of accessory muscles. I don't know if you caught all that in the video. If you didn't, go ahead and watch it again and see, and then we can talk a little bit more in detail about distress. Okay, so while talking about respiratory distress, it's important to note the difference between distress and failure, right? So respiratory distress occurs when there's an increased work of breathing, but that child is still compensating. They're maintaining their oxygenation and their CO2 elimination. However, this compensation can only last for so long before leading to respiratory failure. So then that child can no longer maintain adequate gas exchange. And you may hear nurses say something like, they're going to tire out soon, which is a big concern with small children because when they get tired, they code. So during your assessment, you're really looking for the following. This list here gives you some symptoms, right? We have tachypnea, tachycardia, stridor, wheezing, accessory muscles. The ones in bold generally you start to see as things are getting worse. Grunting can be seen in mild to moderate as well, but I usually have personally seen it more in the moderate to severe. The important thing to note here is that frequent assessments are paramount because it's really important to intervene with these kids early. You want to stabilize your patient prior to being transferred to the ICU so that they can have a controlled intubation versus a crash with an emergent one. As I had mentioned before, most pediatric cardiopulmonary arrests begin as respiratory failure or respiratory arrest. And so if you have a respiratory patient and they are decompensating over the course of your shift, it's really important to get in there frequently and to see when things are starting to turn, because they can sometimes go like that and it can be really scary. So what are our cardinal signs of respiratory failure? How do you know that patient is getting worse? You're going to see increased restlessness or irritability. You're going to maybe notice some sweating or diaphoresis, periods of apnea, worsening severity of their work of breathing, decreased SpO2 despite oxygen delivery, things like that. So when this happens, there are several things we can do. We can use shoulder rolls to reposition the head so that airway isn't obstructed, even elevate the head of the bed to allow more lung expansion. We can suction secretions. That's really important, especially with kids that have RSV. Increasing the oxygen support, administering any ordered meds like nebulizers. Now, if these things fail, we're moving on to bag mask ventilation rapid response, right? So it's really important to always ensure that your emergency equipment is available and functioning properly, because these crashes can happen fast and you don't want to be caught without resources. Okay, so this concludes this part of the respiratory lecture. We'll dive into specific upper and lower disorders in the next few videos. Have a great day.